Hello and welcome to this OncLive Peer Exchange, Improving Outcomes in Relapsed and Refractory Diffuse Large B-Cell Lymphoma. I'm Dr. John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital in New York. Joining me today in this discussion are my colleagues, Dr. Nathan Fowler from MD Anderson Cancer Center in Houston, Texas, Dr. Cami Maddox from Ohio State University in Columbus, Ohio, and Dr. Matthew Lunning from University of Nebraska Medical Center in Omaha, Nebraska. Today we're going to discuss a number of topics pertaining to the use of novel agents in relapsed and refractory diffuse large B-cell lymphoma. We'll discuss newly available agents, the latest research in the field, and the impact of recent clinical trials on making decisions around treatment selection. Let's get started on our first topic. I wanted to introduce our discussion by highlighting some of the current approaches and unmet needs in diffuse large B-cell lymphoma. As I think this audience knows, R-CHOP chemotherapy is the standard treatment for most patients with DLBCL. We do have a number of different subsets of DLBCL that we may at times treat differently than with R-CHOP. In some cases, so for instance, primary mediastinal lymphoma, we may choose R-EPOCH. In double-hit lymphomas, we may choose R-EPOCH as well. But for most patients, we stick with R-CHOP. One exception that might be out there is the mini R-CHOP regimen, or a dose-reduced version of R-CHOP. In cases of patients who are elderly, have comorbidities, may not be able to tolerate standard R-CHOP. But I'm going to ask our panel, and I'll start in a second with Dr. Lunning. Are there any other patients besides what I mentioned that you might treat with other regimens? And if so, what else is out there that you commonly use for DLBCL patients? Or is my summary pretty much in line with what is described?
No, I think I agree. You know, the double hit population is always interesting. EPOCH is commonly used, and we had the result of the CLGB trial, which had some of those patients in it, which randomized, dose-adjusted EPOCH versus R-CHOP. One of the things that I often think about when I'm seeing these patients in the second line, because they have either relapsed disease or primary progressive, is whether or not they were dose adjusted during their EPOCH. And I think that that's something that's out there. If you look, at least in the CLGB study, I think the median number of dose increase or dose adjustment was 3. So for those, if you're not dose adjusting and looking at, twice weekly CBCs to either dose reduce, because sometimes the regimen may be too toxic at the current doses, but also to be considering going up on the dose if they meet parameters, because that's, how it was initially studied and had been what now, I think it's 1993 was the first publication. So we're over, 2 decades of using EPOCH in diffuse large B-cell lymphoma, but we should, in my opinion, try to be sticking to how the recipe was made if you're going to use it.
So Nathan, what about at MD Anderson? I know when I visited there some time ago, there were patients receiving infusional doxorubicin. It's been a place that's kind of been on the cutting edge. What is new there, or what are people doing in practice for large cell lymphoma up front?
Thanks, John. So I would say in general, in patients, in general is a tough word because it would suggest that we treat everybody with a similar frontline regimen. But I think CHOP-based approaches with rituximab, as Matt pointed out, are the standard of care. We kind of tweak those. For example, in patients that are maybe a little bit older, I think almost universally use infusional doxorubicin over 24 to 48 hours. Still outpatient, but we often send patients with a pump. As Matt pointed out, double hit patients pretty much all get R-EPOCH. There is this kind of gray zone, no pun intended, for patients that don't have double hit histology but present with a very aggressive large cell lymphoma. And so these would be patients with a really high Ki-67. The pathologist comes back and says it's an aggressive looking disease under the microscope. And maybe the PET scan is really high, or they have a lot of LDH symptoms, a lot of high symptoms or high LDH. And those patients, I do see a lot of my colleagues will sometimes lean towards R-EPOCH. and this is kind of a gestalt that these patients, even maybe the MYC is not positive, but they have some other, something else is driving this tumor to behave more aggressively. And those are kind of the two scenarios in patients that are chemo eligible, right? I think that's a different conversation. I'm sure I'd be interested to hear what other people do in patients that won't tolerate chemo, but yeah.
Cami, your approach with higher risk patients, is there anything different you do as far as prognostic scores or other high risk features that cause you to deviate from R-CHOP?
The only thing that I would add, and this is adding to R-CHOP, is looking at patients who are at high risk for CNS progression or relapse. So there's a CNS IPI score, and calculating that in patients who are high risk will add methotrexate for prophylaxis, either as IT or as IV. Typically, we would do 4 intrathecal treatments or 3 intravenous treatments of methotrexate, and also do this in the double hit patients where we give dose-adjusted R-EPOC. Otherwise, I would say, I approach it like the others.
So I would kind of summarize the unmet needs, and I'm going to ask all of you to kind of put your thoughts in on this. I mean, it seems to me like the main unmet need is obviously to cure more patients. We cure the majority of patients, but there are certainly, whether they're identified by prognostic scores or pathology or other features, we want to cure those patients. I think we want to improve tolerability of treatment as well. Certainly getting R-CHOP is manageable for most people, but we'd like to do something better. To some degree, I think we'd like to get away from chemotherapy. It'd be nice at some point if it was better tolerated, to have an approach that didn't include chemotherapy, cured more patients, was easier to tolerate, hopefully affordable. But it seems to me like those are some of the key things. Any other thoughts on kind of unmet needs as you approach it, Matt? Your thoughts beyond that?
Well, I think that it's just trying to get more of the IPI 3 to 5s into the upfront clinical trials in diffuse large B-cell lymphoma, finding mechanisms to do that. We spent a lot of resources. The CLGB study was a multi-year study. As we move into the next generation of the Alliance study, for instance, which is looking at that really high risk population, about finding novel strategies to really capture those patients so that, the data that we see at the end, people aren't coming up to the podium and saying, well, that's not reflective of the real world experience in large cell lymphoma. And so really trying to work on, novel strategies to get those patients into the randomized clinical trials.